Hello, everybody. My name is Yolanda Hipsky, and I'd like to welcome you to the second roundtable meeting that we're having on non-emergency medical transportation. I am also joined by Leslie Cocker, who will be our facilitator for today's discussion. And I'll also like to recognize some of our roundtable working group members who are here: Jonathan Dayton, Nancy Huggins, John DeKluski, Sarah Seitz, and Megan Darcy. Just right now, we had our, we've been meeting since March, and I'd like to go around the room quickly and see if we can, everybody can introduce yourself, what region you're from and what organization. My name, as I said, my name is Yolanda Hipsky. I'm from the Tri-County Council for Southern Maryland, and I represent the Southern Maryland.
Hello, everyone. I'm Mika Robinson. I'm the Minority Health and Health Equity Coordinator at the Calvert County Health Department.
Darlene Valentine, Family Health Care of Hagerstown, and we're Western.
Laura Pennington, Family Health Care Community Outreach Worker.
Lorena DeLeon, Senior Director of Population Health for Maryland Physicians Care, and we're actually statewide.
Good afternoon. My name is Todd Smith. I'm representing Boonesboro Ambulance Rescue Service out of Washington County and also Maryland Fire Chiefs.
Felicia Green, the Supervisor for Non-Emergency Medical Transportation within the Wacomico County Health Department.
Hi, Heather Aqualo. I'm the Mobility Manager at Allegheny County HRDC, and I am Western Maryland.
Hello, I'm Jackie Crabtree, Washington County Community Action Council Transportation Director. And here's my director.
I'm Jordy Newman. I'm the Executive Director of the Washington County Community Action Council in Hagerstown.
Good afternoon, Nancy Huggins. I'm with the Office of Local Transit Support for the Maryland Transit Administration, Maryland Department of Transportation.
Hello, everyone. My name is Sarah Seitz. I'm Director of the State Office of Rural Health at the Maryland Department of Health.
Hi, everybody. I'm Bev Marple. I'm a nurse navigator in the emergency department at Garrett Regional.
Bill Valentine, Allegheny County with the Rural Maryland Council Executive Board.
Ryan Davis, Tri-County Council, Western Maryland.
Renee Nisley, I'm the Executive Director of the Local Management Board in Allegheny County, and we're in Western.
Good afternoon. I'm Courtney Thomas Winterberg. I'm the Director of the Allegheny County Department of Social Services.
Good afternoon, Chris Sable, Executive Director of Carroll Tech and Innovation Council. We're out of Central Maryland in Carroll County.
Good afternoon. I'm Jonathan Dayton, Executive Director of the Maryland Rural Health Association.
Andrew Weil, Shore Transit Director, Tri-County Council, Lower Eastern Shore, Maryland.
Is that everyone in the room? All right.
We also have some people on Zoom, which Megan, would you like to? And Charlotte.
Good afternoon, Charlotte Davis, Executive Director, Rural Maryland Council. Thank you all for being here.
Megan DRC with the Rural Maryland Council.
Sharon Smith with Partners in Care Maryland in Central Maryland.
All right. And so I guess we can start with the folks online. Again, I'm Leslie Coker. I'm with the Maryland Acres Program, and I'll be co-facilitating the session today. And I'll just go down the list, call first name, and you can introduce yourself and where you're from. So John
Hickman with Beacon at Salisbury University.
Thank you. And then the other John Hartline.
John Hartline, Executive Director of Tri-County Council for Southern Maryland, Chair of the Rural Maryland Council.
Thank you. Betsy
Bridget from Southern Maryland, Calvert County Health Department. I'm assist with transportation supervision.
Thank you. Dominic
Butchko, Maryland Association of Counties.
Thank you. Don Melton.
Don Melton, RN Care Coordinator at Tidal Health.
Thank you. Elizabeth Beck.
Hi, everyone. I'm Elizabeth Beck. I'm a program manager with Montgomery County.
Thank you. Elizabeth Roman.
Hi, I'm Elizabeth Roman, Director of Population Health, UPMC, Western Maryland.
Thank you. Jeanette Jeffrey.
Hi, I'm Jeanette Jeffrey. I'm the health educator with Rural Healthcare Transformation at University of Maryland, Shore Regional Health in Chestertown.
Thank you. Julie McCoy.
Hi, I'm Julie McCoy. I'm the Executive Director for the Allegheny County Chamber of Commerce.
Thank you. Ken.
Good afternoon, Ken Oldham. I'm the CEO of United Way of Frederick County.
Thank you. Lenny.
Lenny Pfeffer, Dorchester County Council.
Thank you. Linda. Linda.
Hi, I'm Linda Stansberry, Chairman of the Charles County Area Council on Aging.
Thank you. All right, and now we have Molly Sherman.
Molly Sherman, Carroll Technology and Innovation Council.
Thank you. Nan.
Good afternoon. I am Nan Mann, the Western Regional Director for Senator Van Hollen.
Thank you. Patricia.
Hi, I'm Patty Dorn with the Consumer Education and Advocacy Unit of Maryland Insurance Administration.
Thank you. Rob Sherman.
Hi, Rob Sherman, Transit Manager for the Town of Ocean City, Maryland.
Thank you. And lastly, Wendelin.
Hi, good afternoon. Wendelin McKenzie, Western Maryland, Executive Director for Allegheny County HRDC, which is the community action agency serving Allegheny County.
Thank you. And then I have a couple of people that it seems I missed. Sharon.
Good afternoon. This is Sharon Smith, Director of Transportation for Partners in Care Maryland in Pasadena, Maryland.
Thank you. And I have a W. McIntyre, looks like.
Wendy McIntyre, Worcester County Grant Manager.
Thank you. All right. And over to you, Yolanda.
Thank you. Thank you, Leslie. Excuse me, there. Okay, so what exactly are we trying to do here? And I know when I say non-emergency medical transportation, and particularly in the healthcare field, most people are think of Medicaid. But we're thinking a little bit more comprehensively. 1 out of 5 missed transportation trips is caused directly because of transportation. One out of 5 trips to medical appointments, doctors, are caused by transportation. And that's what we're trying to fix. And I know you've heard the story 100 years ago, kids used to walk to school in the snow, uphill in July. And somebody in Wayne County, Indiana got the idea that, if we take these kids and put them in a wagon, take them to the school, they're going to learn better. They're going to get better grades and they'll get better educated. That was a paradigm shift. And that was the paradigm shift that created our school bus system. What we're trying to do here is something on the same level, but with healthcare. What we want to do is we want to help. We're talking about the kid who had, the 10-year-old kid who lives 15 miles away and has a cavity, the size of the Grand Canyon, but dad's car is broken. He can't get to the dentist. We're talking about the dialysis patient who has to go to that chair 3 times a week and, for 4 hours a pop. And if they don't, you're going to see them in the emergency room. We're also talking about one thing we heard from last time was people who need to have a simple procedure taken care of, but they can't get to their appointment. So they call the emergency room. They call the ambulance to come pick them up. Those are problems. What we're trying to do is we're trying to change the paradigm. So this is our second meeting. Our first roundtable meeting was held on September 29th in Cambridge. And at that time, we reviewed basically reviewed the definitions of what is non-emergency medical transportation. And we had a very good conversation of our current programs. Today, at our second meeting, we're going to continue to review and analyze our findings and see if there's some foundational concepts that we could explore a little bit further and to try to develop those concepts and ideas into some strategies. And on November 17th, which is, I'm sure everyone has marked on their calendar for National Rural Health Day, we will be meeting at the Maryland Department of Agriculture in Annapolis where we'll be fine tuning those concepts into some viable strategies. And then there will be a report that should be finished, will be finished by December 31st. So at our first roundtable meeting in Cambridge, and that the Delmarva was held at the Delmarva Community Services Building, we had about 40 people in attendance, both in person and remote. And there was a very strong transportation representation, which was about half. We also had a very robust conversation, which was about 4.5 hours. Today's talk will not take so long, so we'll need to keep on track. And because we were reviewing our current programs, the first roundtable conversation focused on existing gaps in service. And for example, there were gaps with the working poor who are chronically ill. There were rural and urban deserts that we heard about. And we heard a lot about rural patients who need to get to regional urban centers for specialized care, but they had no ride. And because there was no Uber or Lyft service or anything like that. We also heard about dialysis patients who need to get to their appointments, and that population group will quickly overwhelm the local transit system budget to get them to those appointments, leaving very little for other services. We also heard about patients who need transportation for very simple procedures, but because there was no transportation, they would call the ambulance for help because they had no other option. And just to tell us a little bit more about some of these gaps, I'd like to introduce Jackie Crabtree really quick, if she could just give a few minutes of some of her programs that she's operating.
Well, we operate on emergency medical trips. Oh, they can always hear me.
On the internet.
Yeah, okay, sorry. We operate the non-medical emergency trips. We take people from Washington County to Washington County doctors, hospitals, dentals, physical therapy, anywhere they need to go. The issue is the grant that CAC worked with Community Free Clinic to get approved for 2 years only pays enough for 2 vehicles a day for all of Washington County. Therefore, we have to deny some trips. And we do have a variety of illnesses. We take dialysis people. We have to get them scheduled because it's very important that they get there. The problem is scheduling. People will set up schedules, and we're setting our schedule, and the doctor cancels for the client. The client has COVID, or the client's sick, or the client can't go because they increased his rent and he can't pay his copay. So there's a lot of stumbling blocks there and a lot of issues where, we need to get funding for more vehicles, more staff to get them to and from. Now, Jordy wanted to say a few things about it. Hold on, please.
Well, just Jackie was speaking about the need for funding. We received a grant from the Maryland Community Health Resource Commission that covered 2 years of this program with the intent of showing the stats that would encourage our local hospital to then fund this program moving forward. And right now we're performing a little over 300 trips each month. So that's a lot of folks that aren't ending up in urgent care or aren't ending up in the ER, saving the hospital money. So our goal is to show them that funding this program will actually save them money in the future.
Maybe there's somebody in the audience who would want to also talk. I think Gwendolyn.
Yes, well, actually, Heather Aqualo, who's the coordinator of our program, is present, so I'm going to ask her to chime in at some point. But we actually operate the mobility management program, which is a coordinated system of transportation to provide transportation to our seniors for non-emergency health and human services. And it does cover dialysis and other such needs. A big service gap for us, and I thank you for this opportunity, by the way, because transportation is such a tremendous issue and it comes up on every community needs assessment. And I know it's not exclusively an HRDC issue, it's across the county and across the state. So I thank you for that. I think the biggest service gap that we're seeing is in terms of family transportation. We've been approached by a number of individuals who need, it could be, I don't want to make like it's not important, but it could be something as simple as transportation to a WIC appointment. And we currently do not provide transportation to the entire family, but that's something that we're looking into. And I asked Heather as the coordinator, she's there present, to expound on that a little bit and how that works, our coordinated system.
Heather, 1 second.
All right, so our program is a little different than ones across Maryland. We are fare free, which means our clients don't pay for any of their transportation. Is completely funded through outside sources. Some of them, the 5310 grant, which has been instrumental in getting our vehicles. Other is the RMC grant that has helped us fund some day-to-day operations as well. But most of our funding comes from buy-ins. So UPMC Western Maryland has been tremendous in this endeavor with our agency to get people to the doctor's appointments they need. So it's just a simple thing. We have a computer system. It's called TripMaster software. It runs between us and any provider that buys into our program. They can put a request into that, what we call the portal. The request comes to my office. I schedule those ride transportation. We have our own fleet of vehicles. We do have 4, which we've able to double last year. At this time, we only had 2. We have 4 now, so we've been able to grow in that department. But along with our own vehicles, which they are all wheelchair accessible vehicles, we also outsource our rides, meaning that we do send rides through All Trans, which is a form of the public busing system. We also outsource through cabs if need be. And then there's also bus passes that people get on, the stops that go from corner to corner. So we just kind of do what we can to get them to whatever appointments they need. It's all considered non-emergency medical transportation as well. And I believe, it helps keep the cost of care down for UPMC and then any of our providers as well. So the buy-ins is a huge portion of our program. So, questions?
Hi, if I may jump in, this is Libby Ruhlman. And so I do want to say that Heather and Wendelin, they have been fantastic partners for us at UPMC Western Maryland. But I will say it has been very, the costly for UPMC. So we do invest. I can tell you our bottom, like the minimum that we pay a year is $250,000 in transportation. And I'm sure it extends beyond that. And so then we do still have gaps for weekend dialysis, maybe even patients that are in the emergency department that are homeless or do not have, maybe their family dropped them off. And then if they came in Saturday night at 10 p.m., and then we do not have transportation on Sunday. Our taxi services do not run on Sunday. So that creates another barrier for us. So we end up having to hold people in the emergency department on Sundays. And, so it's like Heather said, it's a wonderful program and we definitely have buy-in with them. We love partnering with HRDC. But there are still some gaps and some barriers and it's very costly. And on top of that, we really are unable to quantify the benefit. We are offering services, we're offering transportation, and then how do we know we really are making a difference? We don't know. In the beginning, I think we were able to do that, but I think the word got out that we offer transportation. So now I think that a lot of people are jumping in saying, well, we don't have transportation. And so we're paying for people that maybe have transportation that, are just expecting now the hospital to cover it, unfortunately. So there's a lot of different variables with this. But, of course, we want people and patients in the community to get the healthcare that they want and that they need. And then also the preventive care, we have tons of services for the community, tons of preventive education services. And so that makes it difficult too. How do you weigh which services are more important than others? Is this a post-hospital visit, or is this going to see a dietitian, or is this going to see a health coach? And so, you know, you have to weigh all those options too, because you have to watch your bottom line. So I'm happy to be on this committee, or, you know, this call. And like I said, you know, Wendelin and Heather have been fantastic to work with, but, you know, to find a solution, you know, a transportation, transit, a healthcare transit system like the school system, as you mentioned earlier, would be ideal. Thanks.
Is there anybody else who would like to comment on this?
Well, I have a question for Heather. So when you say buy-in, so
Make sure to speak.
Sorry, I have a question for Heather. So when you say buy-in, is it actually they're actually paying for services?
Yeah, so. Yes, so we do it one of two ways. One, we can do a yearly buy-in, and then we send out quarterly reports to say where your money has been spent. They have to, of course, approve all rides. They're the ones that send me the rides, so we know they're approved through them. With that, you know, that they get we just keep track of the money. Or some of them opt to, I want a monthly bill. I want more in charge of what my financiers are going towards each month. And then I send them a bill each month and they can turn around and pay that way.
So then how do you determine how much they're going to be buying into? What is the fee?
So there is no set fee. It's at their own discretion. So if a company that's newly starting out says, okay, I only want, just throwing a number out there, I just want to do $500 this year. Okay, we'll do a contract with you for the full calendar year. I'll keep a report. Say we get to May and they've spent their $500. We can do an addendum to add more funds for the rest of the year if they choose. Or if not, they won't provide any more rides for their office for the rest of the year, and they'll wait till next year to buy back in again. It's very much at their own choice.
So is it done by contract then?
Yeah, it's an MOU with them. Yeah.
So this is Ken Oldham on the phone. Who is they? Who are the actually people buying in?
Who's they?
The companies that we have. So UPMC, Western Maryland, of course, is our largest. We do have the health department, a company called Committed to Change, Center for Hope and Healing, and Progressive Physical Therapy are our current. We are going to be on kind of a crusade for now between now and the end of the year to get more doctors' offices to participate in our program. We just got our promotional stuff back. So doctors, if you're out there, if you have any of them online, I will probably be contacting you sometime now between now and December to try to buy in for the new year.
The providers?
Yes.
Most. Okay, thank you.
Welcome.
So you're mainly a vendor, right? That's providing the transportation services, meaning that the healthcare systems, the providers have to front you the money in order to do it. You're not coordinating with the larger transportation out there, meaning the MTA or any of the Ubers or Lyfts that are out there, or triaging. You're just focusing on a specific need and delivering based on the 4 fleet. You said 4, right?
Well, we have 4.
But
then we do.
Sorry.
We have our own fleet of 4, but we do outsource some rides through cabs, depending on what time their appointments are, if they have to be there before or after our hours. And then we also outsource through All Trans, which is a branch of our local public busing system. They perform the rides, but we pay the bill for it.
Yeah. Okay.
So
got
it's
it.
all trans part of Allegheny Transit. Is that what you're saying?
Yes.
Okay.
Yeah.
Okay. Because we are kind of exploring something a little broader, where it's almost a piece of the puzzle.
Yes.
You would be providing a service,
Mhm.
but then there'd be additional people providing additional services.
Yes.
Because transportation is not just and I don't know, Courtney, if you'd like to take this one, but we've been doing a lot of discussion around this across Allegheny County, and I think she'd probably be best suited.
Okay.
So I'm very familiar with HRDC's model because I was there at the time we implemented the program through a grant through the HSCRC and then a federal demonstration grant. The design of it was to become self-sustainable through the buy-in of providers. Obviously, some providers like UPMC has seen a greater benefit in that and continue to support it than others. But that was the goal, was to make sure people were getting to their appointments and there would be less appointments missed. That way, doctors' offices would have a steady stream of people in their waiting rooms, people would be getting the care they needed. What we're doing now, because that system is up and running and it's been sustainable for a number of years, is looking at how else we can tackle the transportation problem in Allegheny County, because it's more than just a need for people to get to medical appointments. It's really a need for quality of life. So we're looking at this, instead of looking at it from a lens of transportation of last resort, looking at it as a transportation for all model, because we really do believe that it's the solution to being able to solve transportation challenges, particularly in rural communities, is to really be partnering with both the nonprofits, the government entities, and then the private providers, so that we can build out a continuum of services that can meet everyone's needs. And one of the things that we're looking very closely about is how we can utilize technology to really help that come to fruition. And so there is a local committee that Lorena is participating on through the Allegheny County Chamber of Commerce. Julie's on the phone, that we're actively looking at this and looking at how we can scale some of these solutions. You want to talk? And Renee here with the local management board has also been very involved in transportation over the years, had previously been with HRDC and did the implementation of the mobility management program.
There are some efforts underway. You may want to consider looking at. There are some efforts underway that you may want to consider looking at. I think we've aggregated a tremendous amount of data. There's been a survey that's been done and pooled the community for needs, both non-medical as well as medical. UPMC has been involved in it heavily as well. And additionally, we have a company, TripSpark, which forwarded the invite. They'll be attending the one on the 17th, which is a platform who has capability of pulling all of this together. And they've done it in other states as well as other countries.
Right. One of the things I think we're seeing is there's a tremendous amount of money that's going into providing transportation services in communities, yet it's still not meeting the needs. So it's not just we need more money, but how can we more effectively and efficiently utilize the resources that we currently have?
Part of that is a lack of coordination. The other thing that we have been doing is collecting the data for Lyft and Uber to expand their network. Initially, when we tried to do this as an MCO, we were very small. And so they kind of laughed at us. But then when we brought in UPMC, the colleges, Department of Social Services, now all of a sudden it's a multi-million-dollar significant opportunity. So they're listening.
Hi, this is Ken Oldham on the phone. Interesting you should bring up Lyft and Uber. So we ran a quick poll last year to gather what, if anything, local community leaders knew about Lyft and Uber and how they were affecting transportation in our community. And the answer was next to no information. So we ran a pilot between the months of November and June of 2023, November 2021 and June 2022, called Ride United, which is a partnership with Lyft as the provider. We provided nearly 5,000 rides total and gathered an incredible amount of information, about 18 to 20 data points on every single ride. And now we have a much better feel for what Lyft and Uber do in our community. About 25% of the rides were healthcare, non-ambulatory healthcare related. About half of those were mental health services. But 52% of the rides were for employment purposes. So when we're talking about outside medical care, let's not ignore getting to and from work as a basis of our local economy. We are now in the process of expanding that network to provide to fund and resource other nonprofit ride providers in our community. So I'm delighted to be here and to explore some of these other funding models that we might have in our community. Thank you.
Okay, we, to keep us on track, as I said, our roundtable working group, after the first meetings, we met several times and we found out we determined there was three primary focus areas. The first one was focused on, involved coordination. And specifically, there's a lack of coordination between the healthcare and transportation providers. The second focus area was dealing with the industry characteristics, specifically since socioeconomic status is connected to health, and since demand exceeds services provided by social welfare, transit, and healthcare, the characteristics of the industries need to be evaluated, between them to make sure they match. And the third area is the unique patient challenges. Non-emergency medical transportation provides unique patient challenges, and coordination is critical for effective services. And today we're going to study these three areas and try, find some strategies that will help us work. And to help us with this stage, I'm pleased to introduce Leslie Coker, who will facilitate the discussion.
Thank you. All right, and so you're gonna go to our next slide, and make sure we're at the right place. Thank you. All right, and so what we're gonna do now is talk about the first focus area, which is coordination. And what we found from the survey, and also what also came out in our last meeting, was that there's a lack of coordination between healthcare and transportation providers in many different ways. We already mentioned funding, coordination, just the use and different levels of non-emergency need, et cetera. And so now we're going to utilize our polls again. And this is the information that we were able to gather from our polls. And so let's see here, make sure we're on the right slide. Yeah. We just passed the other slide, and that one was talking about this industry. So, and again, these are polls that were given prior to today. But basically, just looking at this poll, you can go to the "What industry do you represent" slide. Are you all there? Okay, thank you. No.
We're at the slide that says, where does your organization receive most of its funding for? And this just shows that, many of the organizations receive money from, it's pretty scattered from the health department, MDS, MTA, OLTS. And on the top of that, over 27% of the respondents received funding from other sources. So sorry, Leslie.
Hey, one moment. No, it seems that, because I'm looking at one slide deck, it seems that we may have changed the order. So it's no problem. I'll just go from your screen that you have up here. Sorry about that. All right, and so now looking at the slide that's currently up, as you can see, largely we had folks did not know what services were currently available in their area. But, some folks did know where free or reduced bus transportation was available, share for services and so forth, all the way down to not many people knew where like gas cards were for access to get some sort of compensation for gas or discounts, lower gas prices. And so as you can see, this roundtable and many, hopefully more to come, they're needed so that we can hopefully start to problem solve and come up with ideas to get that coordination and get that awareness out there. We can go to the next slide. All right, and so as you can see from our poll results, when we asked that question, why is there such a large amount of folks who are not aware of non-emergency medical transportation? Largely, it was because people are really just not clear on their roles in providing non-emergency transportation. And again, funding, who's paying for what are the hours of operation for certain organizations, really having an understanding of what demographic you need to be identified with to be able to access those services. Those were the types of things that came out in the discussion in our last meeting. And then of course, there's not as much in the areas of folks not knowing because it's not their area of expertise or the information is not there to find, but it's really more so about just not really having that clarity and definitive roles in the transportation industry. Right, and next slide. Yeah, all right. And so here we have in your community, you know, who is eligible? So who can receive non-emergency medical transportation? And most people chose Medicaid recipients. So folks think of Medicaid recipients, oftentimes they associate folks who receive Medicaid with being beneficiaries of free services or additional services. And then it looks like, you know, we have people with disabilities and their elderly population, 65 and older, you know, folks associated that population with having a need for non-emergency medical transportation. But as you've seen, not as many people felt that, you know, low income or folks within three-quarters of a mile radius of a bus route or some sort of public transportation hub, or even homelessness. And then some folks just, you know, chose other, which other really, you know, wasn't defined. So we don't have, you know, clear idea of what folks were thinking about with that, but they just didn't want to choose the other options. So they don't think that any of the folks that are listed here, those populations represented here, are eligible, but maybe some other groups. All right, and so we can go to the next slide. All right, and so with thinking about all of the different things that we just, you know, kind of reviewed, so many of you were here and some of you actually participated in the survey, and all of the different agencies represented here, we wanted to go ahead and do the first whiteboard exercise. And we are going to do this together, so we're not going to work out. So we're going to try to incorporate folks in the room and folks online in this exercise. But the question that we're posing to you all is, if you were king for the day, how would you expand coordination between various agencies and various levels of government? And so we will be able to take your hands online. If you raise your hand, we can have you answer the question in the room. Of course, Yolanda and Megan are in the room, so they'll be able to let us know who in the room is raising their hands. And so are you going to share? I'm going to go ahead and share my screen. I'm just going to make sure. Yolanda, who's taking notes? I can share my screen and take notes from here if it would be easier for everyone.
I could do that too. But if you feel more comfortable, I'll be fine with that too.
That's fine. It would be, you know, yeah, I can.
Might be better. Wouldn't it be better to have a record keeper and a facilitator separate?
Absolutely. I just wanted to make sure that
the
folks online could see. So if we could just take this opportunity to share the screen.
Do you want the whiteboard screen or you do a Word document?
I've got a Word document.
You want to use, yes, we're using the Word document.
Sharing this screen and share your other screen.
Little technical difficulty.
I'll just take a minute. And so just think about that question. And also I know that you have some of this information, you know, in thinking about some of the challenges that you already discussed when it came to coordination, you know, not just locally, but across counties and cross jurisdictions. If you did have a magic wand, or if you were able to just have the perfect proposal in your mind, have it be accepted by those above, what would you pose? And so let's just see a little bit longer for, I'm just gonna start. Are you all?
There we go.
You got it? Okay. Wonderful. So with that, you can again raise your hand online or in the room. You can definitely just, all right, good. I have Lenny online in the room also. You know, let Yolanda know, and someone just indicates to me that people in the room want to speak. So Lenny.
Thank you. In a perfect world, in my mind, I would see a situation where we had one common phone number, similar to a 911, a 333 or whatever, but a common phone number where people could call into, and then that dispatch center that they're calling into would be trained to know the resources throughout the state and be able to direct them to the agency that can provide them the best assistance.
Thank you. All right, and then we have a few more hands in line, and something in the chat, so I'll go through the hands I saw in the chat. Molly?
I think mine would kind of come right before Lenny's, like having a landing page for transit providers to go to where they could make their services known, or somebody who is already organizing services can just make it known to a common party that those services are available, and then out of that have a phone number like Lenny's, or a different type of landing page where somebody in need of transportation could just do a Google search, like how can I get to the doctor's office, and then be able to plug their needs into a front-facing website and have some options available to them.
Thank you, Molly. Gwendolyn?
I think it's all going to end up tying together, because to me that resonates to a coordinated software system that would certainly encompass both pieces. But I also think a coordinated fleet. I mean, we all have, I mean, there's HRDC vehicles out there, there's Allegheny Transit. I think if we had a coordinated vehicle system, that would be beneficial too.
Thank you, Wendy. Dominic?
Yeah, so Dominic here, Maryland Association of Counties. Has anyone reached out to Maryland 211? Because right now they do a lot of this coordination for other social services. I would imagine there is some overlap between non-emergency medical transport and what they offer. And if you want a centralized landing page or a space that you can get, you know, the message out and information to people, I feel like that they would be like the natural choice. So just a suggestion there.
Thank you, Dominic. And then I do see from Elizabeth Rule, patients that need more advanced care in the Baltimore area would have access to follow-up care without cost to them. Did you want to elaborate on? Okay. Did you want to just say that, or I can read the rest? Well,
Sure. Like one of the challenges, or frequently the challenges that we have, is maybe we will need to outsource, and I don't want to say outsource, but we maybe transfer a patient to University of Maryland or Johns Hopkins for a specific type of surgery. And at that point, that's okay. From the inpatient side, we can get that covered. However, from the case management standpoint, it is challenging to get the follow-up appointments, especially if someone has surgery. Because no one wants to touch that surgical patient if they didn't do the surgery. So we've been able to arrange some video telemedicine visits. However, it really comes down to, can we get that patient to the areas that they need? Because as you know, in a rural area, we do not have every service available to us. We need to connect patients to the more, collegiate areas, the bigger hospitals that have extra services that we are unable to provide. So that follow-up care, and even if we do not transport them from the inpatient side, but maybe they're discharged from our emergency department or discharged from the hospital, and then they need to see a specialist, that poses a difficult situation. You know, we may be able to get them that first, visit, but then all the follow-up and the aftercare and the education, how to care for themselves, it's, there's multiple appointments. So a statewide transportation system, as mentioned before, as like the school systems would be ideal.
Thank you. Thank you. Anyone in the room?
Yes, we've got a couple here.
So a couple of points. 211 is an option, but it does present a lot of challenges for the hospital systems as well as the managed care organizations, because we can't track the outcomes. And so that becomes important, right, is to know the ROI on the programs. So, we've had discussions around that. Many of the MCOs are already looking at their own social determinant of need platforms and contracting. Part of this is also doing, like we do in the healthcare system, do a strong needs assessment first, right? Who is everybody who needs rides, right? What are the different types of rides that they need for, to have in place? Some people will be able to ambulate, and so they'll have certain vendors. Others are going to need wheelchair. Other are going to be a full ambo transport, right? And really kind of go from there, develop that criteria, because then what you can do is, based off of a platform very similar to the model that you guys have, you can operationalize it, and you can look beyond medical. That's part of the reason that we've already kind of built out those Visios and those models in order to address this, because the funding source needs to be pooled. I mean, they always say follow the money, right? You can do a lot if we all come together and